Associate Professor Martin Kirk is head of the Field Epidemiology Training Program Australia, namely the Master of Philosophy in Applied Epidemiology degree offered by the Australian National University. Kerry Viney is a research fellow with the MAA team and completing her PhD there. You can find out more about them in their biographic summaries in this subsection of the course. We were fortunate to be able to interview Martin and Kerry about how epidemiologists in the area of infectious diseases deal with the unknowns that inevitably arise in this domain.
So thank you for coming. You're both applied epidemiologists, and in fact you train Australia's disease detectives. Mm-hmm. Can you tell us something about what disease detectives do and how you go about helping them deal with unknowns?
Mm-hmm. Sure. Well, disease detectives, or sometimes we call them field epidemiologists, they're trained to detect and respond to public health events, so whether that be an outbreak of a communicable disease or an environmental health threat, they're trained to detect that event and respond to it appropriately. So they might conduct an outbreak investigation, assess public health surveillance data, analyse that data, and they have to be able to respond to whatever that threat is. Now, dealing with unknowns, that's something that we have to do with a lot. And one way that we train our epidemiologists to deal with unknowns is providing them with frameworks. And we have a couple of frameworks that we use routinely to deal with unknowns, such as outbreak investigation framework or a risk assessment framework.
And so the outbreak investigation framework might involve 10 steps, but probably the key thing is to recognise that for most of these public health events, they're very complex. An outbreak might occur in a community, cause a lot of community concern. So there's a lot of political pressure, there's a lot of community concern. There might be people queuing in hospital waiting rooms, and there are many unknowns, including the type of disease that it is, what the agent might be, and also what caused it and how to prevent it. And so that's what field epidemiologists do.
Do the field epidemiologists also have to deal with members of the public or key decision makers, authorities and government? And if so, how do you train them to do that?
Well, we would often, risk communication is a big part of training field epidemiologists. So we will usually teach them ways of communicating, making sure that their writing skills and their communication skills are very plain and unambiguous, but also that they can succinctly describe what they do know about the problem, whether it's a disease outbreak or occurrence of disease in the community, and what they do not know. And that's a critical part. And they definitely get engaged with all of those stakeholders you mentioned, particularly people, senior officials in health departments or ministers of health, and occasionally the media as well. And epidemiologists have a big role in explaining how things have been occurring, because sometimes a community can have a very different understanding of what's occurring in their members compared to public health professionals. It's important that a correct picture is given.
So you mentioned an extreme kind of situation just earlier, namely the outbreak of an unknown disease. Are there specific kinds of unknowns that are unique to that situation? And if so, how do you deal with those?
Yeah, look, there are specific types of unknowns. I mean, the obvious one is what is the agent causing it, and most public health relies on laboratory information to work out what the pathogen or disease-causing agent is. And in that instance, health agencies will call up their laboratory scientists to try and develop new diagnostic tests to work out what that agent is, but often the field epidemiologist has to conduct those risk factor studies without that information. So we have to develop a categorisation of who is actually someone that's ill from this unknown disease. So we do that usually based on clinical symptoms and timing of illness and maybe location of where they became ill. And we might have to make recommendations about how to intervene without even knowing what the agent is. So I think the new disease scenario does have some very particular types of issues, and the other, of course, is community concern. And this happens quite commonly in countries where it might be low or middle income, and the diagnostic tests aren't available, but you might have a disease in a village that has high morbidity or mortality, causing great community concern and requires a rapid response.
And I guess some of the other unknowns too are things like infection control. How do we stop this from spreading? Who's most at risk? Are health workers most at risk? Are community members, people who are immunosuppressed? Are treatments effective? I think until we know the pathogen or what's responsible, what's the risk factor, we work with a lot of unknowns actually, and the job of the field epidemiologist is to describe everything with as much information as they can so that we can eventually try and explore those unknowns and ascertain them. Sometimes we don't find out all of the unknowns, but if we don't, we write up what we find and we add to the body of scientific knowledge on this particular public health problem, and we add to the knowledge in that way. And I think incrementally we often add to the knowledge on a topic even if we haven't been able to discover all of the unknowns about that public health event.
There's some interesting tensions around trying to conduct the epidemiological study and the need to intervene as well. And so a health department might actually have to tell people to do things even though they don't understand what's causing the disease, and we haven't finished our studies.
So two of the extreme examples of a disease that we didn't know what the cause was were AIDS and SARS when they started. And as you just said, often you have to take action before you actually know what's going on. How do you, as field epidemiologists, how do you advise somebody like the minister or the bank manager who rings up and says, how do I protect my customers? Should I be wiping the doorknobs? Or the mother who rings up and says, how do I protect my children? How do you how do you make decisions about unknowns in those circumstances and help people to act effectively? What are the rules of thumb that you use?
The way that we would normally do it is we'd try to communicate what we know about the risks through the media and social media and other sources. SARS was an interesting example where international health agencies got involved, including the World Health Organization, and they rapidly set up a network of laboratories to try and work out the diagnostics, to work out what agent it was, and they have to go through a long list of different bacteria, viruses and protozoa which might be causing this respiratory disease. And they eventually did identify that it was a coronavirus. So in those new disease settings, there's often a very complex architecture which gets called into play of health agencies around the world that actually try to solve the problem.
You're an expert on foodborne diseases. Are there unknowns that are specific to outbreaks of foodborne diseases? Could you give us a typical example of those?
Yes, foodborne diseases are defined as illnesses that occur after people have eaten a specific food or a contaminated meal. Outbreak investigations of foodborne illness are usually conducted by a team of people, including microbiologists, epidemiologists and food safety officers. There are many different unknowns, but the primary one is what was the actual food or meal that a person ate that made them ill. So what we would normally do is we would normally conduct an epidemiological study. Say for instance, a number of people, say 100 people went to a restaurant and 40 of them became ill with salmonella infection, which causes gastroenteritis. We would then conduct an epidemiological study asking them about which foods on the menu they actually ate. And we would make a statistical comparison about the foods that people ate who became ill and compare it to the foods that people ate amongst people who didn't become ill. We can work out what the relative risk of people becoming ill is. From that, we might identify the food. But the obvious question is, what went wrong in the kitchen? The foodborne disease investigation team often doesn't get past identifying a specific food. They don't necessarily get to be able to understand what happened in the kitchen because it might have happened a day or two earlier, or even a week earlier for outbreaks that are notified late. But we would ideally want to know, was there a contamination event that occurred in the kitchen? So someone not washing their hands properly or chopping up raw meats and salad vegetables on the same chopping board without washing. Alternatively, it could actually be a contamination event that occurred to an ingredient that's come from the field. So it could be fruit, for instance, that might have been served in a fruit salad that's actually being washed in contaminated water in even another country. So that is a very tricky unknown to deal with. And the way we would normally deal with that is we would try and do trace back of ingredients back to their sources for the implicated food. So there are 3 sources of evidence that we rely on in foodborne disease investigations. Microbiological, so tests of bugs on food and surfaces in kitchens. Epidemiological, that's statistical comparison. And then finally trace back, tracing the food back to its origin where it's been implicated in illness. And putting all that together gives us a good picture of what might have happened.
Right. Kieran, your expertise is a little different. You look at tuberculosis, and you've got a particular expertise on tuberculosis in the Pacific. Are there issues around unknowns with tuberculosis that are different? And are there issues around working in other cultures that complicate matters? Are there things around that you can talk about?
Yeah, sure. I think one of the biggest unknowns for us at the moment is knowing actually how many patients have TB in the Pacific or any community, even globally. So it's estimated that about 3 million people globally have TB and they're not detected. They're not notified to TB programs. They haven't come to a health program and been diagnosed. So I guess there's a big push globally to detect people with TB who might be out in the community, are sick, have got some kind of lung problem. They perhaps have been to a health clinic, are misdiagnosed, sent home, whatever. So that's the first unknown that we have, that there's a big burden of illness out there and we need to detect them. And programs have different ways of going out and finding those people, and that's called active case finding. So globally there's a very big push to do that. In the Pacific, we think there are about 2,000 TB patients who are undetected. So there's a big push in the Pacific to go out and do this active case finding, go to areas where there's a high incidence of TB, screen people, make sure we screen people who are immunosuppressed, who have a higher risk of developing TB. So I guess that's our first unknown. Globally and in the Pacific, we need to find patients. With particular reference to the Pacific, and I've done a lot of my work in the Pacific in countries like Vanuatu and Kiribati, some of the unknowns revolve around beliefs about etiology for TB. So we did a survey in one country and we interviewed patients, so these are people who have actually had TB and been diagnosed, and even some of the patients believe that TB doesn't have a bacterial cause, but it's caused by witchcraft or hard work or laziness or smoking or a range of other etiologies that we know are not, causative of TB. So there are lots of unknowns, I think, for community members about TB, what the etiology is, how to treat it effectively. So I think globally we have a big unknown about how many patients are actually in the world who have TB who are undiagnosed, and more specifically, I think for community members, patients, traditional healers, there are still some beliefs about etiology, and for them it remains unknown actually how TB is caused, how it can be treated and how it can be cured.
And so by etiology you mean causes, right?
Yes, yeah.
Okay. That was great. Is there anything else you wanted to add?
The only other thing I would say is that communication of what we don't know is one of the single biggest challenges, whether it's to a minister, whether it's to people in our team, whether it's to the community. They often don't want to know that we don't know stuff. And we're always left with holes in our jigsaw.
No, I agree with Martin. We do have to deal with unknowns, and I think as scientists and epidemiologists we don't like having those unknowns, but I think because we're also public health people and we want to protect the health of populations, that's our main role, we have to move forward. And I guess using sort of risk assessment frameworks and various tools, I think that's one way that helps us communicate risk, but also communicate that there are some unknowns.
Thank you both very much. It's been fantastic.
Yeah, super.
Thank you. Thanks.
We loved it.